now. It just turned 10 o'clock according to my watch. And appreciate you guys paying attention. I know you could be rage watching the impeachment proceedings, but here we are. So I want to talk, this is something that comes up on the trauma service about once a year at least, and probably for you guys as well, about the importance of communication, the potential for impacts on outcomes related to miscommunication. And I think in times of crisis and crises, it becomes especially important to pay attention to our communication. So I want to frame this around a patient that, a trauma patient that came in mid-April. And of course, probably many of you were staffing the ED and wherever else, even the ICU during COVID. Remember, we still had trauma patients. I remember on April 5th, we had a quadruple shooting and a stabbing to the chest, and that was at the height of our COVID census. And ED was filled with intubated people, patients, adult patients who'd been shot had to be sent to the pediatric emergency department. So those moments really present us with a challenge. So this isn't one of those cases, but it was soon after. And I'll get right into it. This is an 87-year-old woman who was brought down after a fall down 15 steps, just going through the basic ABCs, which we should do every single time. Her airway was clear. She was phonating. Breath sounds were clear. And the circulatory exam, which I'll get through quickly, but for you guys, when you present anything to me, my circulatory exam includes not only hemodynamics and pulses, but the exam of everywhere where they can hide exsanguination that could be life-threatening. So the chest exam is part of circulation, belly exam is part of circulation, pelvis exam is part of circulation, IV access is part of the circulation exam. So she had adequate access, breath sounds were clear, belly soft, a little bit of right hip tenderness, but stable pelvis and good pulses peripherally. In the disability, she had no neurologic deficits, and she had signs of facial trauma and no other really additional signs of trauma. On the adjunct on the workup, we see this pelvis exam that shows an intertrochanteric fracture. She got a pan scan because of the mechanism, and I think she was a little bit, her GCS was like 14. She was a little bit disoriented, which didn't show anything beyond showing a little bit more detail on what it caught on this pelvic fracture. We see on the right, this hip fracture, this intertrochanteric fracture, which does actually extend down the femur a bit. And we can see a little bit of a hematoma medially, but there was a good arterial phase, no signs of extravasation. And some labs came back, which basically showed a little bit of an elevated lactate, but it's essentially a normal hemoglobin, slightly low, but nothing terribly concerning. And so at this point, she was admitted to the trauma surgery service and cleared for orthopedic repair of the femur fracture. And at some point, and this happened, as we can see here from the timestamp, close to sign out, I think, for both the ED and the trauma services. And at some point during that conversation, there was a request for a additional blood gas, which came back a couple hours later. Let's see, can I call on people? Kathy, can you unmute your mic? What do you see in this repeat VBG from 850? Kathy Chu.
The lactate is 5.6.
What else do you see?
Her hemoglobin also dropped 3 from 10 to 7.
Yeah, go ahead, sorry.
She's a little bit acidotic as well, 7.2 from 7.3.
Yeah, she has a lactic acidosis and a drop in her hemoglobin. That's not a critical value for hemoglobin, but it should set off alarm bells for us that, wait a minute, now she has signs of metabolic acidosis, signs of hypoperfusion and that lactic acid at the same time that her hemoglobin is dropping. This looks like she's bleeding more than was anticipated or appreciated in her initial evaluation and scan. So just as Kathy, you said the first number you saw was the lactate. The lab, that was the first number that they noticed as well. And so, they have a system where they had to call and get a read back from a provider. So the patient was at this point still in the CCT area. So they called the phone in the CCT. And somebody picked up who was not caring for the patient and called the value out loud. And that became the critical value call. So that's something we'll keep in mind. So what was her clinical course from there? About an hour, a little more than an hour and a half after that call, she had some transient hypotension with worsening mental status, somnolence, and then actually became briefly bradycardic. She had been given some atypical antipsychotic, which she takes at home, around the same time that she got some morphine. And so in the initial reevaluation that was done at that time, this change in status was interpreted as being related to the medication. So she got Narcan and Epi. She perked up at least briefly. And it appears in going through the chart that there was a reevaluation. Someone noticed that drop. A CBC was ordered to really evaluate the hemoglobin, and blood was ordered from the blood bank. There's another VBG here. Kathy, since I had you last time, what do you see on this repeat VBG?
Her pH is 7, her hemoglobin is 5, and her lactate's 12. So it's definitely looking a lot worse. She looks like she's bleeding and increasingly acidotic.
Yeah, and matter of fact, I would say that this looks like a patient who's about to die, especially if we consider the time course on how it's worsening. And I suspect actually this VBG probably was sent around the time that the patient started to become hemodynamically unstable during a reevaluation of more senior trauma people. Cordis was placed and she got emergency blood around that time. But in somewhere between that and getting intubated, she had a PEA arrest. And after resuscitation, CPR, epinephrine, intubation, she had return of circulation. But soon after that had another arrest. And the family, once becoming more involved, had said she would not want ongoing extraordinary levels of care. And so she was made DNR and she expired several hours later. So I think we can already see there was, this is what we call in the surgical literature, and probably the same for you guys, is a failure to rescue. There was an opportunity, most likely, to change the course of this patient's, traumatic clinical course that was missed. And a big part of that was failure to communicate. I'll get back to that in a minute, but one of these quotes that I like is that the biggest problem in communication is the illusion that it has taken place. And I think that that's what we see in this case, is that there were mechanisms in place that were supposed to make sure that certain red flags, or whatever you want to call it, were communicated to the providers responsible. And even though there was sort of a readback process, there wasn't actually communication to the people that it needed to get to. These are some stats in looking through literature related to patient errors and or medical errors and poor patient outcomes. And that we can see, it seems like a large percentage of those are related to, could be chalked up to errors in communication, including a large number of errors reported by residents. A large number of poor outcomes in the ICU, in particular, may be related to poor nurse and physician communication. And in analysis of poor outcomes and medical errors, it's mostly felt to be related to communication rather than incompetence, shall we say. So I'm going to present a little bit of a framework for communication and then some concepts. And I'm sure you guys at some point in your career have already become aware that a lot of what we use in medication related to high stakes communication comes from aviation. And there's a couple of reasons for that. But one is that, errors in aviation can lead to really poor outcomes for hundreds of people that were supposed to have really good outcomes from the procedure, right? They also, interestingly, I think, aviation has a history rooted in the military, so sort of a hierarchical culture. And I think at least in surgery and probably in most of medicine, there is also this hierarchical structure historically. And so I think some of the ways that aviation has managed to ensure effective communication has been very helpful in the operating rooms and in patient care in general. But so I'm going to look at some barriers potential barriers to communication. Some of them are systems, the clinical environment. Obviously, once there becomes less and less time, more and more pressures, more and more distraction, rapidly changing a clinical environment, which I think is what happened during COVID, that introduces more opportunity for error. And we'll talk a little bit more about that further on. There's interpersonal factors, related to, like I said, hierarchy or unfamiliarity, or rapport, trust between the team, or any other cultural factors. And again, during COVID, we remember that the structure of our teams, the composition of our teams were changing. And I suspect that it was true in the ED as much as in the ICU and on our surgical services. Personal factors, whether a lack of self-confidence or perception of fear or emotion, and then training, whether there's formal training, whether there's a formal feedback systems that have been implemented and trained, and so one of the terms that you're going to see if you look into, especially aviation communication, is this idea of crew resource management. Closed loop communication, I'm sure we're familiar with. And I'll talk briefly about graded assertiveness, which is a way of allowing effective communication that challenges a hierarchical structure while still respecting that hierarchy. And then just formalized handoffs as we think about changing between teams, especially in the last 5 to 10 years. The idea of residents living in the hospital has changed to having more shift work. And there's benefits to that in terms of the individual physician, their wellness, and is how they, whether they're equipped to deal with a particular situation. But increased handoffs also introduce increased complexity and increased potential for error, particularly with regards to communication. So the idea of crew resource management comes out of a little bit in the 60s, but really starts to be implemented in the 70s. There was a series of aviation disasters, if you want to call it, including a collision in 1977 that some 500 people died. But another one that happened around the same time that I thought was very interesting is that there was an aircraft that had problem with the landing gear, and in trying to troubleshoot that, they ended up running out of fuel. And so we can see that, when you're in a crisis, that can lead to, we always say in surgery that one complication begets another, and that's what happened in that case. But the point related to crew resource management is, and I mentioned this earlier related to hierarchy, I don't know about you guys. I came from an anti-hierarchical kind of background growing up. But that being said, right, when we're in a trauma activation or in the operating room, we can definitely see the value of respecting the hierarchy of people who have more experience, more training, and ultimately more responsibility related to the circumstance and the outcome. At the same time, we recognize that everybody is capable of missing something, of getting tunnel vision and ignoring important information, or otherwise just making an error in judgment that, once thinking it out loud, they might recognize. So this is a way of having people who are lower down in the hierarchy raise a point and even challenge their supervisors or whatever you want to call it. And the way that this is a 5-point kind of framing of that is first sort of a opening or introduction. Say, hey boss, state your concern, clarify the problem, and if there's a solution that's apparent, state the solution, and then ask for feedback on that. And I think, this is one framework, but basically everyone who has any training, including the nurses and the techs and anybody else who has experience, should be empowered to raise a point related to patient safety and get that attention paid to that. Another point that was missed in this particular case was the closed loop communication, particularly with the callback from the lab, where a call from the lab made it to a phone in the emergency department, but not to anyone who was taking responsibility for the care of the patient. And even within the trauma bay, when we're taking care of patients, the closed loop communication is very important. If we're shouting out things that need to be done, unless there's someone responding, okay, I will do, in this case, will you place the large bore IV? Yes, I'm going to insert the large bore IV. And in fact, I do this all the time. And I think in the lay world, people get really confused. But I often just say, I'm just doing read back confirmation or closed loop communication. And at least in the hospital, people understand what that means. But definitely in the trauma bay, in the emergency department, in the operating room, if we're just shouting something out, or even on the text messaging, I always say, if you text me something and you don't get a affirmative response, I did not receive the text message. And I think that when there's communication without a closed loop, we kind of have to assume that the communication was not received. Maybe this isn't in the best order. Perhaps that should have been first. And then when we talk about the crew resource management, if that initial framework or paradigm is not effective, another way to approach it is what they term graded assertiveness, but is really just an escalation of urgency. First, you probe by asking a question, do you see what I see? And then if that's not, doesn't get the response, say, hey, can we pay attention to something I think is important? And then even challenging, say, can we please stop doing this thing and look at this other more important thing? And then what I call pulling the fire alarm is when we just say, stop what you're doing, because this is dangerous. And this can be difficult to do. And I think that's why the grade of assertiveness, it's much easier to ask your superior a question. And that's why we try going from the easier to the more confrontational, but something to keep in mind. And again, all of these, we can't have chaos. I don't know if anyone has ever been in a trauma bay when there's an open argument. That's really undermining of our ability to take care of the patient. And if the patient is awake, it undermines their confidence in our care. So these things really should be preserved to be used on issues of patient safety. We shouldn't be shy about raising our voice to advocate for the patient, but it doesn't mean that we should be willing to argue and undermine the structure of our systems and teams. And the other point has to do with handoff. This is, we have another, I'm forgetting now what the acronym is in our trauma system. What acronym do you guys use in the emergency department for sign off? Do you guys have an acronym that you use?
IPASS.
IPASS, okay. And what does that stand for? Nobody can answer, right? Is there a student maybe that can, then an intern? No? All right, we'll come back to that, I guess. But the point is that structured handoffs allow us to I always talk about active sign out. And I didn't learn this as an intern. It was only kind of later where I realized that when I'm listening to a sign out, that's the best opportunity, or at least the first best opportunity you're going to have to raise points where it's like, well, what's, someone describes a patient. Well, then why, what's your assessment? Why is that going on? And then, well, what's the plan for that? And if you don't have a good answer for one of those things, then you have a to-do list. It's say, okay, there's something either was missed by the previous team or was missed in the communication to me. And we need to go back and better understand what's going on and have a better plan. If that means, calling an attending or calling a chief resident or going bedside and reevaluating the whole situation. So I think having a structured handoff really gives the opportunity for an active sign out from the receiving team, and to make sure that if things are missed, it won't prevent you from missing everything, but at least let you identify when things are missed so that they can be addressed right away. And probably everyone is familiar with this Swiss cheese model. And the basic idea is that, there are many opportunities to rescue or to identify a potential mistake, right? If, let's just say if we're talking about an order, a medication, there's first, the attending or the chief talking to the person who's on the computer. That's the first step. The second step is them writing it in. The third step is at the pharmacy where they can call up and say, hey, that order doesn't make any sense. And then the last step is the nurse is going to administer. She can, he or she can also say, this doesn't make sense in this clinical circumstance, right? Or I don't understand this order, right? And I think what we saw in crises, whether it's mass casualty or whether it's COVID, which is throughout the whole hospital, March, April, May, is that these little wheels with holes in them, rotated or shifted or completely disappeared. The structure of our teams changed, the acuity of our patients changed, the number of alarm bells going off at any given time changed. And so I think there was an increased opportunity for error because of the change in our systems, particularly if we don't have good insight into how our systems have been changing. So I want to come back to the date of that incident. And just because there was a higher potential for error in times of crisis, I think we should all recognize that even when there's not a time of crisis, we're susceptible to these errors. But, as I mentioned, those Swiss cheese holes rotate and get more porous during crises. So I wanted to think about what was happening different in mid-April. And I can certainly say for our trauma service, we had different attendings. It was not trauma attendings, it was general surgery attendings generally. The resident cohort changed and was different and had less senior people available because the amount of manpower that was required in the ICUs. I think that definitely affected care on patients like this. ICU capacity change. I remember the day that this happened, and there were no ICU beds. Certainly not COVID negative ICU bed that was available right away. So perhaps in a normal time, there would have been an opportunity to escalate this patient that we didn't really have the opportunity to do quickly in mid-April. I'm guessing that the ED census was different at that time, more patients, higher acuity. And I'm guessing based on, what I was experiencing in the hospital, in addition to that acuity, there was more alarms. And so more alarm fatigue, right? More times that they probably never hung up the phone between the lab and the ED, right? Just constantly calling out elevated lactate or elevated CO2 or hypoxia. And so we know that the more times that we hear alarms, the less importance we give to each alarm. I don't know if anybody, Chris, I see your name on my list. Anyone want to say anything else that was different about the ED in mid-April compared to before or after? No?
We also had a lot of ice. Go ahead.
I think in addition to getting many phone calls from the lab, we're also getting many phone calls from families and having to have long conversations with them, which were pretty tiring also.
Yeah. And was the composition of the teams in the ED different as well?
No, not in April. They were pretty similar.
Okay. And I put this at the very end because I don't want to blame the patient. I think that's a bad habit when we blame the patient for our bad outcomes. But it's something to keep in mind is that, geriatric trauma patients are a little bit of a different class of patient, and they can fool us. They do not tolerate physiologic stress well, whereas a young patient may have been salvageable who had a missed bleed that we then resuscitated. Elderly people may not tolerate that well. Another issue is that I wasn't a part of this patient's care when they first came in, and I don't recall whether they had any dementia. But something to keep in mind, altered mental status in elderly patients, if it can be, just sundowning, it can just be ICU delirium or ED delirium. But for me, whenever I hear about an altered patient, particularly when they're elderly, I'm thinking about metabolic derangements that are causing this. And I think in this case that that patient's somnolence was a marker of hypoperfusion that was misinterpreted. So I think that whenever we see elderly patients with altered mental status, we should have a checklist of metabolic problems that we, are they septic? Are they hypoxic? Are they hypercapnic? Are they hypoperfusing? And we have to satisfy those questions before we chalk it up to another etiology. And one last point, this goes for all, not just geriatric patients, but transient hypotension is a marker of poor outcomes or a predictor of poor outcomes in trauma patients. So again, even if it's equipment malfunction, whenever I see in the record or on the screen or notice even one poor, one hypotensive reading, it makes me a little bit anxious, makes me a little bit concerned that that this is a harbinger of the future of hypotension. So something to keep in mind, these were clinical signs in the patient that I think were missed. And sort of the opposite of that is also a little bit true. Sometimes really young, healthy patients can actually, before I do that, another thing that many patients, geriatric patients, will have medications that will cloud some of the signs that we use to diagnose things like hypoperfusion, right? For patients on a beta blocker, they may not get tachycardic, and so we may misinterpret that. On the opposite end, very young, healthy patients sometimes will compensate so well that we don't recognize hypoperfusion until they're really at risk of losing their life when they finally decompensate. So issues to keep in mind on the individual patient side. So, how can we improve? How can we do better between our services, the trauma and the ED services that work together in high acuity situations with a high risk of poor outcomes? Anyone that wants to I don't know how you guys have been moderating the questions. Anybody want to offer some thoughts at this point?
Yeah, I think sometimes when we have a lot of IC borders in the ER, there is, and we've had multiple cases kind of run like this, where the ED is kind of monitoring them, but the other service is kind of monitoring them, and so it gets really difficult. But I think a good kind of solution to that is anytime anything happens to the patient downstairs, just call the team, and if not, drop a note in. I think that's something I do in CCT. If there's an IC border that's kind of iffy, and just drop a note in or call if anything critical during decompensation happens.
If you just drop a note, somebody may not see it or nobody may see it, and you may risk getting it lost also.
Yeah,
So you have to
I'll
make sure
say-
there's person-to-person transfer of information.
Yeah, so one of our attendants said it's probably preferable just to call and not drop a note in, make sure that you're actually notifying them.
You can put the note and document it. Oh,
Yeah, that's what I did, to try to contact so-and-so service.
I think the chat function has become pretty valuable. I think that's something that we can utilize for these types of things.
So the audio was kind of low on that, so I'm just going to restate what I heard for everybody else's benefit. But yeah, the point that when there's a lot of borders, and this is what happens when our ICUs fill up, there's a lot of critical patients are sort of stuck in what I call purgatory, where they're still in the ED, but they've been admitted to another service. And I think that's true, that's kind of a dangerous time where the ED is kind of responsible, but because you're closest, but the primary team is also kind of responsible. And so when there's a clinical change, I think having both services bedside is kind of what I was hearing, to go bedside, see what's going on, also call the service and document it. But I think having both services bedside to make sure that everyone's on the same page. The other part of that is to decompress the ED and to get patients out. I think, what happened in Elmhurst when it became international news is that they were unable to do that, right? They had too many sick patients to put them anywhere in the hospital, and then the ED became overrun. And so even as a system-wide, this time we're sending patients out early. I don't know if the ED has been aware of that, but certainly in our ICUs, we're getting patients that on a systems level have been discussed for transfer to decompress EDs and ICUs and other parts of the system. And so we've built, again, we have the ASU that extra surge ICU is up and running, and largely so that it can decompress the entire system, not just our ICU and ED.
Yeah, and then one of our attendings mentioned the chat function on Epic being a new maneuver that we can use as well for better communication as well.
Yeah, I would just caution on that. I got a chat message from, I think, one of the nurses, but I wasn't in the hospital, so I didn't see it till the next day. So again, unless you get readback confirmation on that message, assume that it was not received. And I think one of the comments sort of address a little bit of this escalation, but I think having a clear kind of escalation policy, especially for these patients who are in that purgatory, right, who are still physically in the ED, and you guys are closest, but there's another service that's responsible in putting orders for them. Having guidelines on what constitutes a clinical change in status that requires a call to that service may be helpful, particularly when that, when it becomes more and more commonplace if our system is a little bit overwhelmed.
Dr. Fitzgerald, there was a question on the chat. From the trauma perspective, what does the service recommend a method of contact?
Yeah, so there's an escalation pathway. I think paging the consult pager is probably the best place to start. Now, if talk to your attending, and if your attending immediately wants to talk to our attending, we have a cell phone that the trauma attending carries in 24 hours a day. Even when we're operating, the OR scrub, or rather the circulator, should pick it up and answer it. So and there's graded response. If you guys have chief's numbers, you can feel free to contact them that way. But again, I would start with the pager. Maybe even an overhead page if you don't get a quick response. And then if you think it needs the attending, then ask your attending to call us. They have our number,
Okay. The other question, someone else also commented that the number's in CCT, the trauma attending's number.
Yeah, I don't want to get a call, the Tylenol call from every nurse and intern, but it's there because you guys if you need to reach us, you have a way, always, even when I joke when we can't reach a service, are they operating? Even when we're operating, I want people to feel like they can communicate with us for urgent patient needs. We have a system set up. Attendings at home will come in if there's more than one crisis at a time, right? So I get upset when that's used as a reason that things didn't get addressed, right? We should feel empowered to escalate to us when it's really a patient safety issue.
Excuse me, hey Simon, it's Mel here. Hi guys, I'm Mel Stone. I'm the new chief of surgery. I just want to really underscore that point that Dr. Fitzgerald is making. Better to call us and it not be anything than to not call us. So I'm telling you from a leadership position, feel free to do that. And any pushback, let me know about it. Thank you.
May I say?
Yes, that's Dr. Rudnitsky.
Yes.
Go ahead.
Yes, whoever is in the attendance, Julia Rudnitsky, it's me. That's my daughter Zoom account. So in terms of the escalation, I do encourage everyone to follow the rules. If it's something real emergent or urgent, it's up to ED provider, attending resident. If there is a CAT scan finding which you think is critical, you call straightforward trauma attending. If there is no response of trauma team, just to remind, they're supposed to respond within 30 minutes to the consult. If there is no appropriate response, you can page one more time. If it doesn't work, you escalate that to attending on call. If attending on call is not responsive, you call Dr. Stone. Believe me, if you will call Dr. Stone at 3 a.m. because I did not respond for your call, he will take care of me, and I will take care of resident. If patient is deteriorating physiologically,
Mutual assured destruction.
yes. If patient is deteriorating physiologically, correct, like this patient who was presented, she was hypotensive in some point, not responsive, correct? If trauma patient in ED, still ED patient or boarding patient deteriorating physiologically and meet any criteria of level 1 or level 2 activation, you call code. If you have normotensive patient who is suddenly 90 right now, you have absolute right to call level 1 trauma code because that's the activation criteria. If the GCS deteriorated from 15 to whatever it is and patient did not get morphine or Versed or something like that, you can assume this is worsening of TBI and you can call trauma code. Do not hesitate. That's it.
All right. So we have a couple more minutes before my hard stop. This is ways of reaching out to me afterwards. My email, I'm on social media. I have a podcast on surgery, violence, and culture, and I'm also one of the moderators for the Eastern Association of Trauma, TraumaCast, which you can look up. But now's a good time if there's any additional questions or commentary. Let me look at the chat business. All right.
I would like to encourage everyone in this communication issue. The majority issues in the many issues in the medicine, it's about communication. It's communication between doctors, communication between lab and doctors, between nurses and doctors, between nurses, between us and family. Many problems in the medicine can be avoided by proper communication. And just to stress out the feedback, that's what is critical in the closed loop communication. Feedback, confirm whatever you heard, confirm the plan. That's the only way to make sure that we are listening and we are hearing, and it's not always the same.
I just want to say thank you so much, Dr. Fitzgerald, for this lecture. I think that it's always a work in process, and there's always room to improve in terms of how services of different types can communicate together, especially in times of crisis. Both of us, I think, will try to work on that as well, and we'll keep in mind about the Swiss cheese and things that can be missed.
And I just wanted to say thank you for having me here. And there's interest in our department and division for doing, joint emergency department and surgery, trauma surgery, didactics, at least every quarter, if not every month. So let's keep in contact and keep doing this.
Awesome. Thank you so much.